Today's topic is spine in ankylosing spondylitis. Involvement of the spine can be assessed by clinical features, appearance of the patient, posture, radiological assessment, laboratory assessment, and clinical tests. Spinal involvement starts at the thoracolumbar spine and finally involves whole spine. Lumbar spine involvement. Usually patient present with a localized pain, referred pain to buttock or posterior thigh, palpable tenderness and paraspinal spasm on palpation. With the time, lumbar lordosis and motion are lost. Loss of lumbar lordosis is assessed by modified Schauber's test. How to do a Schauber's test? Locate lumbosacral junction, mark 10 cm above and 5 cm below. Flex the spine maximally. Distance between the 2 points measured. If the distance fails to expand by distance of 6 cm, then the test is considered abnormal. Thoracic spine involvement. Patients usually present with a localized pain, costotransverse and costovertebral joints, referred pain to chest wall and abdomen. With the progression, tightness of the chest wall and difficulty in breathing will be there. Limited chest expansion and examination. Normal chest expansion at the level of the nipples measures at least 5 cm. If it is less than that, then it is abnormal. Cervical spine involvement may lead to chin on chest deformity, forward flexion attitude with the chin coming to rest on chest, difficulty in intubation. Patients will have difficulty in intubation, difficulty to obtain cervical spine X-ray because of the combination of severe and bizarre flexion, rotational deformity plus ankylosis and osteoporosis will be there. Symptoms of cervical spine involvement. Patients present with neck pain, referred to pain to occiput, shoulder and upper chest. Severe pain plus limited motion leads to progressive ankylosis and kyphosis limiting peripheral vision. Compensatory flexion contracture of the hips, knees as patients attempt to maintain an erect posture. Chin on chest deformity. Long-standing history of ankylosing spondylitis with a fixed cervical spine results in chin on chest deformity. History of some previous injury, how to rule out. Following injury, patient notices pain, increase in cervical spine motion, progressive forward displacement of the head on trunk to the point where flexion is so great that chin comes to rest on the chest. In a study by Gran, it tried up reduced lateral mobility of the lumbar spine, reduced total spinal flexion by less than 40 degrees, reduced total spinal extension by less than 20 degrees. More sensitive and specific test of physical findings consistent with the ankylosing spondylitis. Then what is the mechanism of bony ankylosis in ankylosing spondylitis? Osteoitis, that is localized to joint margin, characterized by the presence of chronic inflammatory cells and granulation tissue, bone tissue in surrounding area, osteoporotic, secondary to increase in osteoclastic activity, subchondral bone fibrocartilage replaced by fibrous tissue. During healing phase, fibrous tissue ossifies leading to bony ankylosis. Changes in spine. Romanus lesion, erosion, the anterior anterolateral aspect of the vertebral rim at vascular attachment site of the annulus fibrosis. Damage to this tissue results in a bony repair process and syndesmophyte formation and ossification of the annular fibrosis, that is a hallmark of ankylosing spondylitis. Osseous changes of this type in thoracolumbar region gives a bamboo spine appearance. In the spine, the early stages of spondylitis are manifested as a small erosions at the corners of the vertebral bodies. The areas are surrounded by reactive sclerosis and have been termed the Saini corner sign or a Romanus lesion. Vertebral rim defect, a localized lesion when a vascular annulus is attached, believed to be a traumatic lesion. Anderson lesion represents a massive destruction of the discovertebral junction. Patients with Anderson lesion have an earlier onset of symptoms. Despite the extensive radiographic changes, most patients are asymptomatic. Sacroiliac joint, they will have a sacroiliitis. It occurs early in the course of the ankylosing spondylitis and is regarded as a hallmark of the disease. Radiographically, the earliest sign is indistinctness of the joint. The joint initially widens before it narrows. With eventual bony fusion, the sclerosis resolves. In imaging, you will see the squaring of the vertebral body. That is another characteristic feature of the ankylosing spondylitis and is caused by combination of corner erosions, periosteal new bone formation, along the anterior aspect of the vertebral body. This is best seen in the lumbar spine, in which the anterior cortex of the vertebral body normally is concave. And this is squaring is followed by syndesmophyte formation, which refers to ossification of the outer fibers of the annulus fibrosus, giving rise to bridging of the corners of the one vertebra to another. Complete fusion of the vertebral bodies by syndesmophytes and other related ossification leads to bamboo spine. Calcification of the disc may occur at a single or multiple levels and usually are associated with apophyseal joint ankylosis and adjacent syndesmophytes. Fractures in established ankylosing spondylitis usually occur at the thoracolumbar and cervicothoracic junctions. Upper cervical spine fractures and antoaxial subluxation are rarely seen. Fractures typically are transverse, extend from the anterior to the posterior, and frequently pass through the ossified disc. They have been termed chalk stick fractures. Pseudoarthrosis. Pseudoarthrosis is seen radiographically as areas of discovertebral destruction and adjacent sclerosis. The changes are referred to as Anderson lesion and may resemble disc infection, although pseudoarthrosis usually develops secondarily to previously undetected fracture or at an unfused segment. CT scan may be useful in selected patients in whom ankylosing spondylitis is suggested and in whom initial sacroiliac joint radiographs findings are normal or equivocal. Features of such joint erosions and subchondral sclerosis and bony ankylosis are visualized better on CT than on radiographs. Coming to the laboratory investigations, they are not diagnostic. There will be increase in ESR positive to HLA-B27. 80 to 90% are positive for HLA-B27. Among B27 population, only 2% develop the disease. Coming to the treatment, it is directed at maintaining flexibility with the stretching of the hip flexors and hamstring muscles, maintaining spinal alignment with exercise, anti-inflammatory medications in symptomatic management, and non-operative measures as a supportive treatment. Coming to the operative treatments, osteotomy of the lumbar spine is done. That the Smith, Peterson's, Larson's and Offronk described osteotomy of lumbar spine to correct flexion deformity. As described by Patterson et al., it was one-stage procedure. Others described as a two-stage surgery. First, division of the anterior longitudinal ligament under direct division instead of allowing it to rupture, when the deformity is corrected by gentle manipulation as in the method described by Patterson. The more deformed lumbar spine are corrected in two stages because of the contractures of the soft tissues and damaging the nerve vessels including aorta, inferior vena cava and nerves. First aorta is freed, then osteotomy is done. Patient positioning. Adams suggested patient lying on one side. It is easy to place a grossly deformed spine, low risk of damaging ankylosed cervical spine by pressure of the forehead against the table, easy airway access and anesthesia maintenance, and clear operative field and assessing blood flow out from the depth rather than into it. Resection of the spinous process from the lamina to the pedicles, simple wedge resection of the spinous process into the neural foramina, chevron excision of the lamina and spinous process, combined anterior opening wedge osteotomy following posterior resection of the spinous process and lamina. Smith-Peterson osteotomy is an excellent option for correction of the smaller degrees of spinal deformity. Pedicle subtraction osteotomy. Best suited for patients who have significant sagittal imbalance of 4 cm or more and immobile or a fused disc. Considered safer than Smith-Peterson osteotomy and because it avoids multiple osteotomies. Correction of more than 30 degrees can be obtained with a single posterior osteotomy. Eggshell osteotomy, both anterior and posterior approach for severe sagittal or a coronal imbalance of more than 10 cm from the midline. Spine shortening procedure. Anterior decancellation, removal of the posterior element, instrumentation and deformity correction and fusion. In the cervical spine, osteotomy of the cervical spine is indicated to elevate chin from the sternum, to prevent antoaxial and cervical subluxation, to relieve tracheal and esophageal distortion, to prevent irritation of the spinal cord tracts or traction of the nerve roots. Law successfully performed osteotomies at the level of C3, C4, C5, C6, C7. He fixed the spine internally with the plates devised by Wilson and Stroop for use in lumbosacral orthodosis. Simmons technique, decompression done first, resection of the inferior aspect of the pedicles, extension of the manipulation is done, overcorrection is avoided as it stretches trachea and esophagus, and it is internally fixed.